Thanks for tuning in. In this video, we're just going to talk about endotracheal tubes, breathing tubes, ET tubes. They have a lot of different names. So keep in mind, when you look at anatomy, it's shown to you backwards. So I'm going to be your patient. So this is my left hand. It's your right side. That way you could lay the anatomy book across your patient, chest x-rays, dental x-rays. So everything you see anatomically is shown to you backwards. So this is the inside of our body. So that's our airway, our trachea in the front. And then it bifurcates. So that's our airway, our trachea. And this spot's called the carina, where it goes left and right. And so this is the left lobe of the lung, and this is the right. So in the front, it's our airway breathing. Right behind it is all our digestion, our esophagus going to our stomach. So how you control where something goes, because our airway lies right in front of our esophagus, is the head tilt chin lift. For the rest of time, the head tilt chin lift is going to be our first airway for two reasons. When you do a head tilt chin lift, keep in mind a human being's tongue is the size of their hand. The tongue is set so far back we don't realize how big it is. But the number one thing all unconscious patients suffocate on is their tongue. So when you do a head tilt chin lift, you force the tongue into proper alignment so they won't suffocate on it, and you force their airway, their trachea, into their thorax. As long as their airway is open, when you give them a breath, the chest will rise. So this goes to my lungs. I've opened my airway. If I tuck my chin to my chest, I completely close my airway. This goes to my stomach. So if I give them a breath like this is going to go to their stomach. If I give them a breath like this, it's going to go to their lungs. And in the middle, it could go stomach or lungs. So when you give them breaths, you only want it going to their lungs. You should see visible chest rise. Now, you're going to be using a bag valve mask, but it's not uncommon for anesthesia, paramedics, ER docs, intensivists to need to put in breathing tubes in your patients. So endotracheal tubes are very easy to understand. Now, when you see an endotracheal tube, you'll see this white port. That's how you're going to hook it into your vent tubing and your bag valve mask. Right past that port is the size of the tube. This is an 8.0. This is very commonly placed in an adult male. And this is a 7.5, so that's in a larger size female. It's not uncommon for an adult female to be intubated with a 7.0 and an adult male with an 8.0. As the number gets larger, your tube will get longer and wider. Now, the tip of an endotracheal tube is going to sit deliberately 2 centimeters above the carina. So here's our carina. So the tip of that endotracheal tube is going to sit right above it, so that when we give him breaths with the bag valve mask, both lungs inflate, or put him on a mechanical ventilator, both lungs inflate. But I'm going to bring the heart over. The heart's coming for a vacation, so it's coming over here for a second. The heart's actually in the way of the left lobe of the lung. Because the heart's over here, there are 2 lobes on the left, but there's no heart on the right, so there are 3 lobes on the right. Since there's 2 lobes, since the heart's over here and there were only 2 lobes, the left main stem bronchi is not very parallel or very wide, whereas on the right, where it's going into 3 lobes of that lung, it is rather parallel and rather wide. So you can see how if the tube is sitting here, how it will always favor the right main stem bronchi. Now, there are many ways to know your endotracheal tube's in the right spot. One way is, once the tube is in, you should have bilateral breath sounds, bilateral chest rise. Your O2 sat should quickly climb to 100%. If it goes in too far, it will most likely slide down over here. So then when you give them breaths with the bag valve mask, this lung will go up and down, and this lung won't. If you're only inflating 1 lung, your bag valve mask is built for 2 lungs, so it'll be very resistant, and your O2 sat will be crummy. So if they intubate the patient and I breath sounds on the right and the left is quiet, I would naturally assume the tube went in too far and it just went down there. So we'll deflate the balloon, back it up. But if you just put a breathing tube in someone and the breath sounds are on the left, but the right is quiet, I'd assume the right lobe of the lung collapsed. So when lungs collapse, they come in. So it's not common at all. I've never actually seen them place this in the right main stem bronchi. But realize, if they did, this lung would go up and down and make sound, and your O2 sat would be poor because you're inflating 1 lung. If you ever have trouble with a tracheostomy or an endotracheal tube, remember the acronym DOPE. The D is displaced, O obstructed, probably with secretions. The P is a pneumothorax, they collapsed a lung, or E equipment failed. But it's one of those four problems. That trach or endotracheal tube is either displaced, obstructed, the P is a pneumothorax, or E equipment failed. So those are uncommon. I would say most of the time, once they get a breathing tube and our endotracheal tube and they're intubated, you're going to 100% O2 sats, bilateral breath sounds, bilateral chest rise. Endotracheal tubes are very simple devices. Now, that's where you're going to hook it into your bag valve mask and vent tubing. That's the size. Here's a ruler. Most of the patients will be orally intubated. Unless their mouth is needed for trauma or surgery, we typically orally intubate someone. If their mouth is necessary for one of those events, we would nasally intubate them. So we'll drop this down about half a size. Can you imagine that hose in your nose? I can't imagine it, honestly. So when patients are intubated, I'm just going to put this in so it's easy, you're going to see a portion of the endotracheal tube sticking out of their mouth. As humans, we're not going to vary much between 2 centimeters above our carina and our lip or our teeth line. You would need a neck like Nefertiti or no neck. It's usually the no neck people. So just realize whatever size tube is in this patient, multiply that size by 3. Adult females intubated with a 7.0, it's usually 21 at the lip. 8.0, it's usually 24 at the lip. It's roughly 3 times the size of the endotracheal tube. Now, it's not an exact science, but we won't vary much as humans from 2 centimeters above our carina and our lip, unless we have a wonderfully long neck or no neck. So say you intubate this female with a 7.0 French ET tube. I'm going to expect that tube to be about 21, so 20 and a half at the lip or 22 at the lip. But if you said, no, we just intubated this lady with a 7 French ET tube and it's 19 at the lip or 23 at the lip, I'd automatically tell you, I think your tube's in the wrong spot. It's about 3 times the size of the tube. Once they're intubated, you can control their ventilation, you can sedate them. Without that, I'm always afraid they're going to stop breathing and we're going to need to sedate them. But once they're intubated, you have a secured advanced airway. Now, this is called a stylet. A stylet, it's like a coated metal hanger, and the stylet gives the endotracheal tube structure. If the stylet were to extend past, it could puncture on the way down. So when who's ever putting in the endotracheal tube, they're going to place the stylet, and when they get to this little oval or the eye, you're going to see them curl the stylet so it doesn't extend. The stylet will give this structure, and once the endotracheal tube is properly placed, they'll pull out the stylet. At the end of an endotracheal tube, you're going to see a little balloon or a cuff. So the balloon's job is to simply prevent air and oxygen from escaping around the tube. This balloon doesn't hold the device in their body. If your patient has a Foley catheter, a urinary catheter, a Foley balloon is an anchoring balloon. Our bladder is shaped like a V, so the balloon full of water in this case prevents it from getting pulled through the urethra and anchors it. Endotracheal tubes will be anchored externally with tape or Velcro, little devices. What this balloon does is prevent air and oxygen from escaping around the tube, so they only breathe through the tube. The cuff or the balloon sits below the vocal cords. So if the balloon is not adequately inflated, the patients make sound like, ah, or you're not supposed to make sound. I know that's a balloon problem. I would probably add 1 cc of air, call respiratory therapy, and they'll check the pressure in the balloon. But that's how you know your balloon is not adequately inflated. That's the balloon's job, to prevent air and oxygen from escaping around the tube so they only breathe what's through the tube. Back to the oval of the eye. They'll not only use that as a landmark with the stylet, if they do, so the Murphy's eye, if they do accidentally put the tube in too far and it favors the right mediastem bronchi, that little hole is going to ventilate the top lobe of that lung. So that little Murphy's eye has a lot of good purposes. It's a landmark for the stylet, as well as if they did accidentally intubate the right mediastem bronchi, that right top lobe would ventilate. When in doubt, take it out. When in doubt with endotracheal tubes or tracheostomies, don't just pull them out. You might not, the patient's airway might swell and you might not get a new one in. Call anesthesia. They have all the fun toys. They're going to bring a bougie. So a bougie, there's a ruler here. They know they're past the vocal cord. So say this is a broken endotracheal tube or tracheostomy. They're going to float in the bougie. They know they're past the vocal cords, and pull out the broken endotracheal tube or airway, and they'll float in a nice new one right over it. So when in doubt, call anesthesia. Whoopsie. When in doubt, call anesthesia. They're the ones that typically place all these airways. And you can change out an airway over bougie, similar to when we change out big central lines over wires, but we change out airways over bougies. I hope this was helpful. Have a wonderful day. Thank you.